Me again. I'm tired of my voice yet. So here is your instructional video on how to do an admission in HospiceSoft. So let's get right to it. I'm going to share my screen and let's rock. Okay. And you all get a copy of this PowerPoint along with the video. All right. So admitting a patient in HospiceSoft. The first thing I want you to know is what are the requirements to do the actual admission. So this document came right from HospiceSoft, and under the admission recertification tab, under the patient's chart, you must do the election of benefits, patient notifications, the physician verbal certification, and we're doing the combined verbal, and the level of care must be assigned. Okay, so I'm going to show you step by step what it looks like. There, under the admissions recert tab, are the things that you need: the verbal combined, the hospice election of benefit, patient notifications, and then level of care is up higher on the screen. Okay. Okay. So now for the hospice election of benefit. Okay. When you open the form up, it's going to have all these sections here. Right. So when we expand the sections, and we do that when we click open all, what we see is the first section is the effective date of the election of benefit, date and time. The hospice philosophy, the effects of the Medicare hospice election. So just so you all understand, when a patient accepts this and says, yes, I want to elect the hospice benefit, what that means is Medicare is the primary. Oops, sorry about that. Medicare is their primary payer. So we bill Medicare, Medicare pays us, and everything that has to do with the care of that patient, we are responsible for. Okay. And we're going to talk more about diagnoses and what's related and what's unrelated later on in this, but this is a start. So that election of benefit is very important. Then there's the right to request patient notification of hospice non-covered items, services, and drugs. One of these must be chosen. Either they elect to receive it or they decline. If you choose that they elect to receive it, what that means is that we are going to provide written notification to the patient and family of what we will be covering and anything that is not considered related and won't be covered in writing. It's a lot of paper. So, typically you explain that to the patient upon admission and find out what they want. So, and again, that is where you use clinical judgment. Here's an example. If you're admitting a patient and they have metastatic cancer, then you need to think about what is related and what is unrelated. Are they still going for chemo? I mean, hopefully not at that point if it's stage 4. If it's heart failure, anything that has to do with heart failure and any other related diagnoses. So if they have heart failure because they have type 2 diabetes, it's related. We're responsible. If they have kidney failure because of the type 2 diabetes, which also caused the heart failure, related. So this one requires a little clinical judgment and thought. Make sure that you're going over this with the patient at the time of admission. Then the right to choose an attending physician. And this is one that I definitely want to talk about because this is an important one also. All right. I'm actually going to stop the recording for a minute. I'll be right back. I'm back. All right, let's go back to this, pick up where we left off. And so, all right. So the right to choose an attending physician. Just because a physician in the community referred the patient does not necessarily mean that they will continue to follow the patient through their hospice journey. We need to find that out upon admission. Because if, for example, this patient, Mildred Pierce, Adam Sandler is her physician, and he chooses to follow her because we called Dr. Adam Sandler while we were at the patient's house just to confirm the fact. Some primary care physicians don't want to. They just remand everything over to our medical director. But we need to find that out, because if they wish to acknowledge that their choice for an attending physician is their doctor, will their doctor follow them? If not, then that means they're not going to choose one, and it will be remanded to our medical director. It's super important because if you click here that they chose this doctor, you better have called and the doctor agrees, because the doctor in the community needs to do a CTI and needs to receive the care plan for the patient and needs to be in communication with us the whole hospice journey. So keep that in mind before this is checked. All right. The next one is, who is the beneficiary and family-centered care quality organization? That's a mouthful. Ours is Levanta. In other words, if for some reason the patient is dissatisfied or the family members are dissatisfied with us, have a complaint, this is who they will be contacting. Okay. And then the last section is the signature of the beneficiary or their representative. Now, this, because we're still using paper, is more or less a placeholder, if you will. Okay. However, you can get the patient to sign here on your tablet. Okay. Print their name in here. Okay. If not, if the patient can't sign, beneficiary is unable to sign, then you need to put the reason here, and the reason needs to be a legitimate and concrete reason. Examples would be, patient is blind, can't sign their name. The patient has contractures of the bilateral upper extremities, they can't hold a pen. Patient has severe end-stage Parkinson's, MS, they can't hold a pen. Patient is severely cognitively impaired. Okay, so in other words, they are not oriented. Times 3, that would be a reason. But you can't just put confused or, wants son to sign. That's not acceptable. So if you check that box, then you can have the beneficiary sign for them, but you need to put in their printed name. And then there's a box at the very bottom that says on paper. All right. Next is the patient notification forms. When you open that one up, what you'll see is something that looks like this. And it's a placeholder because you're going over the paper, or maybe someone already got the consents, I don't know, but either way. So the patient needs to know that they've received the release of information for medical records. Are they limited in English proficiency, HIPAA, privacy practices, their signature page, what our complaint process is, what their rights and responsibilities are. The Medicare is a second payer worksheet, any facility notifications if they happen to live in a skilled nursing facility, et cetera, et cetera. So these need to be completed, okay? And here's the rest of them. The financial agreement, the philosophy of care, what the role is of our members. Who do they call in an emergency? We are on call 24 hours a day, 7 days a week. You don't call 911. The coordination of care plan. Who are we going to be involving? We're going to be involving the patient if they're able, their family member / caregiver, their physician if the physician's following, our medical director, and all of our disciplines, spiritual, social services, et cetera, and nursing. Our bereavement services. Who is the bereaved? That is important. DME, pharmacy, and home health aid services. What to do in the event of a disaster, a hurricane, an earthquake, right? Case management, how does that work, right? Explain that the RN, you're the case manager for them, and you help to facilitate all the other services. If there's any change in the patient condition, again, not 911, they call us. And then any hospice-specific documentation, and then any other comments, like I put here. She would be in the veterans program. She was a veteran. So, okay, that's all important. And then under patient notifications, when you back out of it, you then go over here to finalize and click finalize, right? And that will turn that green check mark into a lock, meaning that form is completed, okay? And then the CTI verbal combine. What you need to do is click create combine verbal. And then what you will see, oh, that is not what you will see. So let me pause this and let me fix this. Sit tight. Okay, that's enough interruptions. Let's go back here and we will continue in our PowerPoint right now. Okay, here we go. So when you create the verbal, this is what it looks like. And if this is blank, then there might be an issue. So see here, it says expected benefit period start date, expected benefit period end date. When you click reload patient info over here on the right, it should give you a date here, which you would then just retype into these boxes. And then medical director, as long as the director was put in, you would click this box and the doctor's name should populate. So should their attending if they have one, right? And if it's the medical director, then he should have been entered in as their attending under relationships. And I'm going to show you that next, okay? And then once that data is entered, you would click save, and then you would click back and you would finalize it, okay? Now, if you click this and nothing populates, what do? Call Ghostbusters. No, what you do is you go to their face sheet, to this that says relationships, view relationships. You would click that. When you do, you would have a box that looks like, kind of like this. Actually, it's a list that pops up, and you would enter in any relationships. So you would, medical director, Dr. Olarsh, this one happens to be, the start date, and who are they? The medical director, and then save. If they were the attending, you would click that. If they're the medical director and the attending, because the patient didn't choose an attending, you would click them both, and then you would click save. And then you go back to that verbal CTI, and they should populate in those drop-down boxes, okay? All right, and then what you'll see is you'll see a nice list that looks like this. Adam Sandler is their attending physician, and Dr. Olarsh is their medical director. So you're good to go. Now you could click back and get back into the patient's chart, okay? Or if you needed to click and add in a bereaved or a caregiver, you could go back and you could click create new caregiver person. I love the way that's worded. And it will let you add the daughter, if she's the caregiver, or whoever, right? And the bereaved and all that good stuff, okay? And then when you click add, create new person, it will give you a box that looks like this that will ask you for the phone, the address label, the address, zip code, et cetera, et cetera. Should we show it on the demographics page? I always click yes. And should it go on the face sheet? Yes. Do they live with the patient? Yes or no? Allow CAPS survey. Make that always a yes. What is the relationship? Well, it's their child. She's female and she speaks English. So you would click all of that, enter that information, and click save. Okay. And then this will pop up and you'll have to put in here, what is the relationship? It's her daughter. Yes, it's a primary relationship. And then you would click that to show that she is the primary caregiver and click save. And when you do that, she shows up as the primary caregiver for the patient. Okay. When you view the list, this is what the list looks like. Now, if you wanted to add that daughter as being the primary bereaved, you would go down here and click add bereaved. And when you do that, it will bring up the list of relationships. Well, who do you want to add as the bereaved? Well, I want to add the daughter, Lily Munster. And I would just click set person as bereavement. And when I do, it would then add her not only as the caregiver, but as the bereaved. Okay. And it'll again ask you for the relationship. It's her daughter, it's primary. Click save. And then there you go. So you see Lily Munster is the caregiver and the bereaved. Okay. And that's important because that will populate boxes for the social worker and spiritual, et cetera. So now when I look at this patient's chart, here's Lily Munster. She's the caregiver and the bereaved. And we have a medical director and we have an attending physician who's also the referrer, and the window witch was the referrer too. Okay. All right. Then when we look at that CTI verbal combined, click edit, and then we can actually make sure that the doctor populates, and the doctor should populate at this point, right? And you can save it and lock it. Okay. And locking it means finalizing. And finalizing a document makes it go from this green check mark to a lock, meaning that it's locked and it's done. And that puts a date and time stamp on it. The verbal combined CTI must be done, locked, and signed that day. okay? Because that has to get submitted within 48 hours. So that needs to be signed and locked that day of admission. Please and thank you. Okay. Next, what is their level of care? On their face sheet, current level of care, you would click level of care update. And when you do, it's going to open this up and you're going to say, well, there aren't any levels of care for the patient, so I'm going to add a level of care. You would click that and you will wind up with this window and it will say what kind of care type. Most patients are routine. I'll do another video explaining what respite is and how we go about doing that, what's general inpatient hospice, the different types of levels of care. Okay, so this we would click the box and we would choose routine home care, which is the most common. What is the start date? There probably isn't an end date. What county do they live in? What location type? Is it a private family home or skilled nursing facility, right? And the code will populate for you. So don't worry about the HCPC code, all right? And then you're going to click save here or save here. Either one will do the same thing, okay? So see, this one is filled in. Routine home care, the date and the time. County, what kind of location? It's their home. Routine home care, and they're not in a facility. I click save, and then we move on, okay? And see, they have a level of care now. If I click the back button or the view patient button, it will take me back to their face sheet. And there we go, current level of care. And it will say routine home care. Next, we have service periods. This one's a little tricky, okay? When you click view service periods, it will open up a window that looks like this. So there's your referral, came in on September 23rd. Do we want to change this patient from referred to admitted? Well, we do. So we're going to go to edit. We're going to click edit, and it's going to open this window up. And you're going to see the referral date and what the referral was. And then it's going to say select next stage with a drop-down box. The next stage is going to be either rejected or admission. Here, it's going to be admission. It's going to ask you if they're uncomfortable because of pain. Where is the site of the admission? Patient's home. Where were they admitted from? Their home, community residential setting. Are they a transfer from another hospice? What is the date and time of the admission? And just a short blip, metastatic breast cancer admitted this date. Right? And then you would click save. When you click save, it will show you the information that's there, and you'll see the service period has in fact been changed to admitted. Then you can go to your nursing note. Okay, so in the patient's chart, the green tab, nursing notes, nurse progress note, you would create a note, and then you will have something that looks like this. So that is your comprehensive assessment for the patient, okay? And then what I like to do is I click open all, and it will expand all of these tabs for me. And I will then, when I'm doing my assessment, go system by system and start completing it, okay? It asks about basic patient information, okay? If no diagnoses have been added, this will be blank. That's okay. You've got 2 days to finish this at most, okay? Are they a DNR? That will populate from their face sheet if it was put in. What is their PPS or KP? Understand this. The PPS versus the KPS. The Karnofsky Performance Scale, which I sent you guys a video on, was originally used strictly for oncology. It can be used for hospice, but the better choice is the PPS, the Palliative Performance Scale. And I will send everyone a copy of that, okay? Is death imminent? Yes or no? And that will populate on its own if you filled it out or if someone filled it out at the referral. What is the start time and the date of your visit? And then what is the end time of your visit? Was your visit done in person or was it a telehealth? Now it should be in person. And log visit count on finalization. This must be checked because it counts towards the visit frequency for that patient. Always check that. Okay. Then goes through family adaptation. And it starts to ask you questions. Please, please, please answer the questions to the best of your ability. And if there's something that you want to add as far as a comment, because, you know, these check boxes aren't always the best. Is the patient coping effectively? If they have dementia and you're telling me that they're cognitively impaired, how do you know if the patient is coping effectively? You don't. So I would write a note, patient cognitively impaired, unable to ascertain. Is the family coping effectively? If there's no family, that would be an A. Caregiver, same thing. Patient and family interaction, family conflict. And if you're checking something like difficult or guarded or they're disengaged, tell me what you mean. Family caregiver's emotional state. If you tell me that they are depressed or fearful or angry, there's a space for a comment. Tell me what, elaborate. So I know what you mean. Okay, like here, Lily, that's the daughter. Lily is sad, but anticipated the passing of her mother. So now I'm explaining what I mean. And did we discuss the satisfaction of the aides' care? Well, this is an admission, so that would be not applicable because our aides haven't been there yet. And under every section, there will be care plans that may be recommended for you, okay? If there are no family adaptation issues, okay, here for family care plan, you would have to override it to make the care plan go away. Otherwise, this will stay red and you won't be able to lock your note. Same thing for goals and the same thing for interventions, okay? And there's a space for interventions, goals, and issues under every single section in that nursing note. Understand that every patient should not have the same exact care plans, okay? And I'm going to go over care plans in a separate video. But I just wanted to go through the basic steps so that you understand initially when you're admitting a patient, what are the first few things that have to be done. And remember this, if at any point you're having trouble or you need help, reach out to me. There's never any harm or shame in asking a question. Honestly, no one knows everything, not even me. There have been times where students of mine have asked me something pertaining to, say, obstetrics. That's not my specialty. So I'll tell them, I don't know that. It's not my specialty, but let's look it up and let's figure it out together, right? So it's okay to say you don't know. That's not a disgrace or a shame, okay? Here you have my cell phone number, you have my contact information, and I lost my dog, Dakota, on Friday of this past week. So I just wanted to put a picture of her up, and this is in memory of her. She was a good dog. Okay, stop the share. And that's it. Remember, please, if you have questions, call me, text me, email me, whatever. But don't just ignore it, right? It's easier to fix something in the front end than it is to try to go back on the back end and repair it. I promise, okay? So that's it for this video. More to come. Boom. All right, bye, guys.